Thank you, Professor Thom. I think there are some very kind words, and I'll try my best to really cover this topic in a way that's understandable and useful for the surgeons. And if it is going too fast, or if you think it's getting too complex, please do let me know even in between the presentation, and I'll sort of change the pace of this. I'm going to speak to you about breast imaging and intervention, and I'll try to keep myself to about 45 minutes so that we have some time for questions at the end. And I'd like to acknowledge Dr. Smriti Hari and Dr. Sanjay Tulkar, also from our department, the senior professors, who've sort of also been sort of talking on this topic for years together, and it helped me put this presentation together. Yeah, sorry. So, when we come to assessment of breast diseases, traditionally we've tried self-breast examination, clinical breast examination, although none of these have actually proven to really reduce the mortality rate. The standard of care for screening for breast diseases today, even today, is mammography, and it's really the only modality which has been proven with large randomized controlled trials to reduce the mortality rate due to breast cancer. Although the sensitivity, specificity has been shown to be very high with ultrasound and MR, currently we do not actually have enough evidence with other modalities that it is capable of reducing the mortality rate due to breast cancer. Most of them help in early detection, but the best evidence that we have today is with mammography, which is why I'm going to take you through some sort of pearls within mammography and what to look out for. Now, this is what a mammography equipment looks like. This is the X-ray tube, and this is the receptor, and this is the compression plate. So usually the breast is compressed while taking a mammogram, which is why often patients who have undergone previous mammograms, you would find them saying that it's very painful to get a mammogram done. And the reason for this pain is really the compression, and the compression is very important in a mammogram, unlike in an X-ray, where gross movement of the patient is a problem, but fine movement doesn't make a difference. But in mammography, even fine movement is extremely detrimental to the image quality. So we cannot allow movement to happen at all. Now, mammography has the highest spatial resolution among all modalities. So often I ask even our own residents, radiology residents, when they begin, and we try to ask them which is the modality with the highest spatial resolution. Most people think it is MRI or one of the higher modalities like CT scan. But the reality is mammography, out of all imaging modalities, has the highest spatial resolution. And this is extremely important because we're trying to detect very fine cancers, and we'll miss them if the spatial resolution is compromised. This is how a patient is positioned for mammography. This is the craniocaudal view where the breast is compressed craniocaudally, and this is the mediolateral oblique view, and this is the position the patient is put in to get a mediolateral oblique projection. So you can see the projection that results from a CC, and this is the MLO view. These are the two standard projections for mammography. And in addition, when we are not able to sort of capture a particular lesion, or you want to see a particular region of the breast in more detail, you might want to do a spot compression view of that particular region. Or when you are trying to do interventions particularly, you might want a mediolateral view where there is no angulation. This is a dead lateral view where the tube is 90 degrees. Or you might want to do an extended craniocaudal view if the lesion is too lateral. So these are all modifications of the views. They're not standard views. The call on doing these views is taken from patient to patient, depending on what the mammogram looks like and where you might find a difficulty in understanding whether there is a mass or not. You might do magnification views. These are views where a particular region is magnified. This is not a digital magnification. Here, the acquisition itself is different, where you project more X-rays per unit area of a particular region in the breast in order to see a particular area in more detail. We don't typically use these in current day, and I'll come to the reason for that. So you can do mammography in a screening setting. In most other countries in the West, there is a routine screening mammography which is invited. usually starts around 45 to 50 years of age, depending on the country. And usually it's done either once in 2 years or once in 3 years, again, depending on the protocol of that particular country. And these are where the large randomized control trials come from. In India, we don't have enough equipment or enough medical practitioners to be able to perform a screening mammogram of the entire population. But what we do offer is something called opportunistic screening. Basically, when a patient has come in to the hospital for another related disease, particularly if it's a cancer, we do offer them opportunistic screening, and we say that now that you're here, why don't we also do a mammogram and look for a cancer in your breast? In addition, you can also have diagnostic mammography. What that means is if the woman is already symptomatic and she's aged at least 30 years of age or over, then we try to characterize these lesions within the breast to ensure that this is not a cancer. Basically, this kind of symptomatic mammography is called diagnostic mammography. And what you're doing is really searching for anything which can be of suspicion. In addition to all of this, post-treatment surveillance actually constitutes a bulk of the patients who come for mammography in India, at least. So post-treatment for breast cancer, this woman is already at high risk of breast cancer because of whatever systemic risk factors resulted in the first cancer, as well as to look for whether there's a recurrent cancer post a breast conservation therapy. So this kind of post-treatment surveillance with mammography actually constitutes a very large number of mammographies that we do. Mammography is not a perfect modality. It's far from being perfect. It has about 15% false negative rate. We can miss cancers. And this is particularly true when the breast is dense. So this is an example of a fatty breast where you see that most of the breast is black. So any cancer which is white over here will stand out very clearly. Whereas in a dense breast where most of the breast is white, finding another white cancer which is hidden over here may be technically challenging. And here in dense breasts, the sensitivity of mammography drops to nearly 30 or 40%. You can use supplemental modalities such as ultrasound. And in this subset of patients where the breasts are dense, ultrasound performs extremely well. It is able to delineate the mass much better than mammography in this subset of patients. Mammography itself has brought in several advances, one of which is digital breast tomosynthesis, and I'll take you through this in the next few slides. Now, this really is the reason that I was saying that we don't do a lot of spot compression views or exaggerated views because of the availability of what is called digital breast tomosynthesis. Now, earlier we used to have something called screen film mammography. I'm sure none of you are old enough to have seen a screen film being developed, but back in the olden days, before digitization became more widespread in radiology departments, technicians had to take silver coated films, place it under the patient, and these needed to be developed over a period of an hour. And this has changed drastically with the introduction of several flat panel detectors. I wouldn't go into the details of the flat panel detectors. I think that's too much detail. But in today's day, we get very good resolution even with digital mammography. We use very high resolution monitors. If you visited the radiology departments of your hospitals, you might have seen these big screens which display mammograms. And this is actually a legal requirement. Legally, you need to read mammograms on a 5 megapixel monitor in order to ensure that you're not missing a cancer. So digital mammography, unlike what a lot of people would expect, does not have a better spatial resolution. It actually has a lower spatial resolution than the traditional screen film mammogram, but it has something called a better dynamic range, which means that the levels of gray it can display are higher, so you can perceive more difference in what is called the contrast resolution, which more than compensates for the spatial resolution. And that brings us to digital breast tomosynthesis, because digital mammogram has enabled another technology called tomosynthesis, where multiple low energy projections are taken. It's not a single mammogram with the tube at the top. It's multiple projections where the tube is rotating across the patient. You can think of it as being similar to a CT scan, except that the tube is not going to go all around the patient, and each projection is not going to be a full energy projection. So a DBT actually uses very low energy X-rays in each projection in order to capture images of the entire breast and then reconstructs them into thin sections. It's called a quasi three-dimensional modality because each section that you get is actually a blurred sort of section. It's not a full energy section. So you don't get a full 3D view, but you get a semi 3D view structure. And this really helps you delineate what might look like overlap. For example, this is a patient with a cancer hiding in here, and it's a little difficult to call this a cancer on a plain mammogram image. So you're not sure whether this has come because of overlap or is this really a cancer hiding in. But when you look at the DBT projections, you can clearly see that there is a mass with spiculated margins, and this turned out to be a 4 millimeter cancer. So this is what the projections of DBT look like. In traditionally, there was when digital mammography was introduced, there was also introduction of something called computer-aided diagnosis. The idea was that can the computer itself sort of learn and prompt the radiologist that look here, there seems to be something suspicious. Now, large trials of CAD over the years actually proved that it ended up increasing the false positive rates, but added nothing to the false negative rate of mammography. And CAD has essentially been abandoned. But in recent times, this has been replaced by artificial intelligence, where there's a lot of hope around how it can potentially help us detect abnormalities. It can potentially help us miss what can be missed by a fatigued radiologist who's reading hundreds of mammograms every day, which can potentially help more inexperienced readers find cancers, and maybe potentially actually screen out a certain section of mammograms and say that, okay, these don't need to be seen by an expert and these need to be seen by an expert because these look suspicious. So there's a lot of hope in the current day around artificial intelligence, and only time will tell how that goes. Coming to dual energy mammogram. Now, a dual energy image is where traditionally, so it can be done with either acquisition at 2 kV values or with 2 detectors. And I won't go into the detailed physics of dual energy, but it should suffice to say that the idea of dual energy is that using the energy of the X-ray beam, you're trying to separate out various contrast ranges within the mammogram. And this has given way to something called contrast enhanced mammography. And this is likely to increase more and more as we go forward from here. So contrast enhanced mammography is where you give iodinated contrast. This is the same contrast that is given in a CT scan. Currently, we give about 100 ml of contrast to the lady, and you have about 10 minutes to acquire the image after contrast is given. So you perform a subtraction image, and what it gives you at the end is an iodine map. So much like in MRI, where you can delineate the contrast kinetics, you can talk about whether this particular mass is enhancing with contrast, whether it is washing out after contrast administration. Similarly, even in contrast enhanced mammography, we are starting to see images which look a lot like MRI, with the additional advantage of it carrying a much higher spatial resolution. So this is again a modality that we are likely to see more and more in time to come. So coming to the interpretation of mammogram, important to take care of certain technical factors. You should have optimum lighting conditions. So if you're reading a film, try and keep it on a view box. Really trying to interpret any imaging modalities, keeping it in front of the tube light is not correct, but particularly for mammography, because you will tend to miss very small cancers. Basic sanity checks. Check that it is the same patient's film that you're reading. This is something that happens very commonly in a busy department, you tend to read the wrong patient. Check the quality of the image, check if it is actually covering all parts of the breast. You should be able to see the pectoralis muscle on an MLO view. You should ideally be able to see a sliver of the pectoralis muscle on the CC view also. You should be able to see the medial fold of the chest wall. And if you are able to see all this, you know that most of the breast has actually been covered. If not, you might be missing a mass. It's not always possible to get an optimum positioning, but it should at least alert you to the fact that a particular part of the breast may not have been covered by this mammogram. Um, I'll take you through some parts of how to interpret a mammogram, and also talk about how the radiology report is actually organized. Um, so, so basically, we always begin a radiology report with the ACR BI-RADS category. This is a categorization of the breast parenchymal density. So when you have a breast which looks almost black with very few strands of fibroglandular tissue, this is an ACR category A breast. This means it is almost entirely fatty. Whereas as you move forward and you find a breast which is almost completely white, this should alert you that you might be missing cancer in this breast. Mammography is not an extremely foolproof investigation for a breast like this. This is an ACR category D breast. It's an extremely dense breast, and B and C come somewhere in between these. So the importance of the ACR category density is to alert you on how sure you are of the findings of the mammogram which is reported in front of you. Now coming to the lexicon which is used. Now ACR, which is the American College of Radiology, gives a very strict lexicon, and which is why the breast reports tend to be fairly structured. You don't typically use words as you wish. Your words have to fit into this lexicon in order to find the descriptors, and this will automatically lead you to the BI-RADS category. So you can describe a particular finding as either a mass, a calcification, an architectural distortion, or an asymmetry. A mass, as you would know, would be something which is dense, particularly if it's dense in the center and becomes less dense in the periphery. A calcification is something which is extremely dense and tiny. Architectural distortion is where you cannot really see a mass. You only see that the fibroglandular pattern of the breast is distorted. And an asymmetry is something you describe in comparison to the opposite breast, where you're saying that typically the breast should look fairly symmetric, but there is something over here that I see which is not very symmetric to the opposite side. When you come to a mass, you will further describe it in terms of its shape, margin, density, and associated findings. The shape of a mass could be either completely round, as in over here, oval, as in over here. Now, round and oval tend to be cysts. They're not very suspicious, and they typically go into the lower BI-RADS categories. They could be lobulated. Typically, fibroadenomas have very lobulated margins, or they could be irregular. Now, irregular is what should make you suspicious. As far as the margins of these masses are concerned, it could either be circumscribed, it could be obscured, which means that you can't really see the margins very clearly. It could be microlobulated. Now, this is an example of microlobulated margins, and you can look at the schematic diagram to help you understand what a microlobulated margin is. It could be ill-defined, where, say, a part of the margin is something you're not very sure of. Maybe there is something hiding over here. Or it could be frankly speculated. Now, a frankly speculated mass would be a BI-RADS category 5. A microlobulated mass would also be a BI-RADS category 4C or 5. Whereas an obscure mass or an ill-defined mass might be a BI-RADS category 0, where you want to do something more, something like an ultrasound, in order to help you define this better. And coming to the density, you can have a high density mass, you can have an isodense mass, depending on whether it is just merging in with the rest of the parenchyma, or a low density mass, in which case it indicates that there is some fat within it. And the mass, if you're able to see clearly fat hiding within the mass, by and large means that this is a benign mass. Coming to calcification, now you describe the morphology, number, as well as distribution. These are the important descriptors of a calcification which help you decide how suspicious the calcification is. The morphology can tell you that it is either totally benign. You can categorize it as something which has an intermediate category concern or a very high probability of malignancy. You see a lot of very benign morphology calcifications in almost every mammogram that you see. You can have skin calcifications. You can have what is called typically the popcorn calcification, which is seen in an involuting fibroadenoma. You can see vascular calcifications, rod-like calcifications, dystrophic calcifications, especially in patients who've undergone surgery before, or if they have some parasitic disease of the breast. You can see round and punctate calcifications, and all of these go into a BI-RADS category 2. There is nothing to worry about in these patients. They do not even need a follow-up mammogram to determine what this might be. You are completely certain that these are benign calcifications. Moving on to intermediate category of calcifications, you can have coarse and heterogeneous calcifications or amorphous indistinct calcifications. Now, these are calcifications which can go either way, and you'll need to either biopsy them or follow them up to see whether the number of calcifications is changing. It's very difficult to take a call. Here, of course, there's a mass underlying it, so you're sure of what this calcification may be. But if you were to look at the calcification in isolation, then it's very difficult to determine what this could be. And a certain percentage, say about 30-40% of them, can turn out to be malignant. So this is a call you will have to take on biopsy only. Whereas some pleomorphic calcification, fine linear branching calcification, now this happens typically in a DCIS, and pleomorphic and fine heterogeneous calcification happen typically in an invasive cancer. So the other descriptor which can help you further categorize it is the distribution. Now it can either be clustered, where a lot of calcification is packed into a tight cluster. It could be ductal when it is linear, particularly when it is coming from the nipple. It could be segmental, which is in the distribution of a ductal unit, or it could be diffusely scattered. Now, if it's diffusely scattered, there is very little chance that it is going to turn out to be malignant. But a clustered or a segmental calcification very often turns out to be malignant, and a ductal calcification very often turns out to be a DCIS. Now, coming to an asymmetry, this basically means that I wasn't expecting this based on what I saw on the opposite breast, and so this is asymmetric breast tissue. Often it can be global asymmetry, which means that there's a lot of breast tissue which is asymmetric, or it can be focal asymmetry, which means that there is something which is mass-like, it's restricted to a particular region, and this is asymmetric. And this should sort of prompt you to look for an underlying mass. You could do a supplemental modality, something like an ultrasound, to look for what is hiding under this. But often it is just using your experience that you sort of decide how much importance to give this asymmetry. And you look at if it corresponds with clinical abnormality. You see the previous mammograms, you see if it is a developing asymmetry. A developing asymmetry is very significant. It is something that you give importance to. You see any associated findings such as architectural distortion, you might choose to do special views, or you might choose to do another modality such as ultrasound to evaluate this further. And the last category of lesions is an architectural distortion. So where you don't see a mass really, but you just see a distorted architecture. Now, architectural distortion can be very significant, particularly in dense breasts, because you don't see a difference in density, but if you do see an architectural distortion, it alerts you that there is something hiding over there. On the other hand, it can also just represent normal post-operative scarring. All post-operative patients do have some degree of architectural distortion. It can represent something like a radial scar or even a granulomatous mastitis. So again, this is something that you will have to take a call based on your experience for. And based on all of this, you give one of the 6 BI-RADS categories. You would already be very conversant with it as breast surgeons, but I'll just go over this just for the sake of completion. A 0 category means that the evaluation is incomplete, and you would want to do something else to look for what's wrong with the breast. So you might want to do an ultrasound, you might want to do an MRI. In our practice, we usually already do an ultrasound for all such patients, and we don't give a BIRATS category 0 for a pending ultrasound. But if you're not able to, if you're in a center where you're not able to do an ultrasound with every suspicious finding, then you might want to give a 0 and call the patient back for an ultrasound. A 1 means that this is an absolutely normal mammogram. There is nothing to be done. You just advise the patient to go back and come back for routine screening. Again, a BIRATS category 2 means it's a completely benign finding, and I'm 100% sure that this is benign. And again, the patient only needs a routine screening. Now, BIRATS category 3 means that it is a probably benign finding, that the likelihood of malignancy is less than 2%. But since it is less than 2%, I'd like the patient to come back every 6 months for another screening, and I would like to follow this mass and just make sure that this is not increasing in size. If I'm able to do this every 6 months for a period of 2 years, I can downgrade a BIRATS category 3 lesion to a BIRATS category 2 lesion. And after that, the patient just needs to come back for routine screening. A BIRATS category 4 is literally a dustbin term. Here, the chance of malignancy can range from 5 to 95%. It is typically reserved for categories of the breast where you're not sure at all and you would like to biopsy. So the management recommendation for a category 4 lesion is a biopsy. This is further divided into ABC, again depending on the likelihood of malignancy. Often 4A lesions are lesions where you only want to, you think it is benign, but you only want to rule out malignancy. So you just want to be doubly sure by biopsying the lesion so that you're not missing a malignancy. But in all likelihood, this is going to turn out to be benign. Whereas a 4C just means that this is definitely almost certainly malignancy, but just to rule out some mimickers, since it does not have certain classical manifestations of malignancy such as spiculated margins, you would call it a 4C lesion, but essentially you're almost certain that this is malignancy. A BIRATS category 5 is that it is highly suggestive of malignancy. Even if your biopsy turns out to be benign, you should go ahead and biopsy again to rule out the possibility of a discordance between the radiology and pathology to ensure that you have sampled the correct region. There is a BIRATS category 6 is reserved for a biopsy-proven malignancy where you've done the mammography only for either looking for additional lesions or for characterizing or for just delineating the lesion for a surgical planning. So I had already touched upon the BIRATS category 3 lesion. We'll sort of move on. Just an example of how you would describe masses really. So if it is round and circumscribed and high density, you would sort of put it into a BIRATS category 2 or a 3. If you're able to do an ultrasound along with it and prove that it is a cystic lesion, a cyst goes into a BIRATS category 2, whereas on just mammography, you will have to still put it into a BIRATS category 3 and follow this up. So this is how a report is really organized, where where after the patient demographics, you write the indication, you write the clinical findings. There is a parenchymal density category always that you would find on the radiology report. And from a surgeon's perspective, this is important in the sense of letting you know of what the sensitivity of mammogram is going to be in this particular patient. The final impression basically includes what you think of the study. It will include a separate BIRATS category for the right and the left, and typically also has a management recommendation alongside this. Coming to ultrasound, now if a lady is less than 30 years of age, she is expected to have a mammographically dense breast. So you might choose to automatically go for a breast ultrasound. Now the only exception in this case is patients where you do know or have a very high suspicion of malignancy, even pre-imaging. That is, clinically, if you have a very high suspicion of malignancy, you might still choose to go in for a mammography so that there is a global view that you have which you're able to record and follow up, say post the neoadjuvant chemotherapy. But in all other cases under 30, you would typically go for a breast ultrasound. And ultrasound is also an excellent modality to evaluate the breast. So often, even for lesions which are detected on mammography or detected on MRI, you might want to do a second look ultrasound. This is because it's much easier to target lesions for a biopsy on ultrasound rather than on a mammogram or an MRI. It's much faster to do it with an ultrasound because it's real time. Now, palpable breast lesions again form a very important indication for breast ultrasound, because often the correlation between what you're palpating and what you're seeing on imaging is the best with an ultrasound, because you can palpate it while you're doing the ultrasound, whereas of course you cannot do that while doing a mammogram or an MRI for that matter. So the lexicon in an ultrasound is very similar. You describe the shape, orientation, margin, lesion boundary, and posterior acoustic features. I wouldn't spend too much time since we've already gone over shape of the lesion in mammogram, but very similar to a mammogram, you describe the mass shape, the mass margins. Now, orientation basically means how is it oriented in comparison to the chest wall. And you describe the echo pattern, which is something like the density and the internal sort of structure of the mass. Posterior acoustic features like if it shows enhancement, this is indicative of a more benign mass, whereas posterior acoustic shadowing, such as you can see over here, is more suspicious. And you have exactly the same BI-RADS categories on ultrasound as well. Now, there are some difficulties in assigning a final BI-RADS category. Now, I would sort of emphasize on these for a surgical audience, which is that how do you give a BI-RADS category to an abscess or a hematoma? Just to stress on the fact that the BI-RADS categorization is really only a category for which is meant for assessing the probability of malignancies. When it comes to other lesions such as an abscess or hematoma, you might refrain from giving a BI-RADS category. As we spoke about tomosynthesis and contrast-enhanced mammogram, those are certain advancements that have come about within mammography. Similarly, elastography is in addition to ultrasound. It's like an ultrasound palpation of the mass. So when you palpate the mass and you see how firm it is, how soft it is, how ballotable it is, how very hard and firm it is, these give you an indication of how what is the suspicion of malignancy. In a very similar way, elastography tries to do exactly the same in a more objective fashion, where you're sending waves into the mass, and you're also seeing how much it is distorting the tissue. And based on how much distortion of tissue is happening, you get an elastography map of this kind. So this usually is made to scale. The scale in this case was that the red regions indicate a more stiff tissue and blue regions indicate soft tissue. So as you can see over here, there's a lot of red over here indicating that this is a fairly hard mass. And studies have shown that elastography is very effective in helping in characterizing lesions. It's particularly useful when it comes to cystic lesions. Cysts give a void on elastography, so if on regular ultrasound you're not too certain whether this is a purely cystic lesion or not, elastography can help you sort of dissolve the doubts over there. It can also help you choose the hardest region of the mass for a biopsy. So it gives you a good map where you can choose which region to biopsy so that you get a good result where you're not missing the possibility of malignancy. Similar to contrast-enhanced mammogram, you also have contrast-enhanced ultrasound. Here the contrast agent which is given is very different from the from the contrast agent given in CT and in mammography. This is actually microbubbles of air which is given, and you need a special mode on your ultrasound machine to be able to do a contrast enhanced ultrasound. It comes with a lot of advantages, which is that you can see, since ultrasound imaging can be performed real time, you can constantly see what is happening while you're giving the contrast to the mass. But it also has a lot of disadvantages, which is that you are forced to look at only one mass at a time and one region and one section of the mass. You cannot really see a global view of the entire breast at the same time. But it can also be used in patients with renal failure, unlike CT contrast and mammography contrast. Quickly, a little bit about breast MRI. At the moment, it is a well-established adjunctive modality, with a lot of proponents of breast MR actually believing that it should actually be the primary modality rather than being an adjunctive modality. You need specialized equipment. You need a dedicated breast coil, so it is not done on the typical body coil that is used for, say, the body MRI. You have standardized protocols for breast coils, and in case you're doing MR guided biopsies, you need compatible needles. Be very careful about that, because the MR equipment, the magnet can entirely suck in all the needles and injure the patient and everybody around, and become, it would need something called quenching if you accidentally take anything metallic within the MR suite. It's said to have a sensitivity of nearly 90 to 100%, but the specificity is only about 50 to 70%, and those of you who use it in your routine practice would relate to this very well. Almost everybody who goes through an MRI, we tend to find some small lesions, and very often, since MR shows up so much, we're very often not able to really characterize it, which is why it is recommended that if you're doing a breast MRI, you should have the facility to do an MR guided biopsy as well, so that you're able to target those lesions that you're not able to really characterize very well, rather than recommending a for all patients who you're doing an MR for. Patients with a very high risk of breast cancer use MRI even as a screening modality. This is particularly true for BRCA1 and 2 patients, who often undergo 6-monthly MRI alternating with 6-monthly mammogram. It's a problem-solving modality where you have an equivocal result in mammogram or ultrasound. You might do it to look for occult primaries in the breast, where the patient does have axillary metastasis, or you can also use it for staging breast cancer, to look for chest wall invasion, to look for multifocality when you're doing a BCS, to look for multicentricity, or to assess the contralateral breast. Another important indication, this is fast emerging in the setting of de-escalation of breast surgery, which is you might want to do it for assessment of response to NACT and to look for residual disease after completion of NACT. And here essentially the hypothesis is that if you are somehow able to prove with MRI and say a guided biopsy that there is a pathological CR, then you might sort of refrain from doing a surgery. Although the jury is really out on whether this is adequate or not for patients, and only time can tell, whether this is going to be successful in selecting the correct patients for surgery. Now you need a high strength, you need at least 1.5 Tesla to do a breast MR. This is what a breast coil looks like. This is how a patient is positioned. She's positioned prone, and this is also important to remember because this is not how your patient is going to be positioned on the OT table, which is why it's not necessary that the lesion is going to look exactly the same on the MR on the OT table. Ultrasound is really the leading modality where you're performing the imaging in the same way as you position the patient on the OT table. For both mammogram and MRI, you have a different positioning, and that's important to keep in mind when you're planning for surgery. You do a pre-contrast T1 weighted image, T2 weighted image, and then you give contrast in a dynamic way, which means that you give contrast, and every 20 seconds you're acquiring images. This is called a dynamic post-contrast imaging. And based on how the contrast is taken up by the particular lesion, you draw something called a time intensity curve. Now, both the things, the morphology of the lesion and the time intensity curve, is very important while sort of taking a call on whether on how to on how much the chance of malignancy is. Any lesion is classified into a focus, a mass, a non-mass like enhancement on mammogram on an MR. So you need to describe it in exactly these ways. It's either a focus or a mass or a non-mass like enhancement, and depending on which one it is, you would sort of give it that you would describe it further in that manner. Now, let's go with a mass, because this is what we're most familiar with based on what we read in MR, in mammogram, and in ultrasound. So you would describe the shape of the mass, you would describe the margins of the mass, and you would describe the internal enhancement characteristics of the mass. Now, this is very similar to what we just saw on the mammogram, and remember that this is more important than the kinetic analysis. It's usually a complex of many factors, particularly when you do an MR, in determining whether this what the BIRADS category should be. So, but by and large, the kinetic analysis is divided into type 1, 2, and 3 curves. If the mass seems to enhance initially but retain contrast, or even enhance slowly but retains contrast, these are a type 1 and type 2 curves. These typically are not extremely suspicious. But when you see a type 3 curve where there is sudden enhancement and then washout of the contrast, this type 3 curve is highly suspicious for malignancy. But as this says, it's always the morphology first. Morphology is much more important in determining whether this is malignant or not. I won't go into too much detail on a non-mass-like enhancement, but this is another descriptor which is often used in the MR reports. Here you look at the distribution, internal enhancement, symmetry of the mass, of the non-mass-like enhancement. And in addition to all of this, there are other techniques like scintimammography, breast-specific gamma imaging, and PET, which can also help you. And if you're interested in all this, you should check out the American College of Radiology guidelines for breast imaging. As I promised to finish this in 45 minutes, I'll only very quickly go over breast interventions. So this is the biopsy gun for core biopsy of lesions. This is how it's done under ultrasound guidance. You penetrate the mass and then you fire. For you might have very fibrotic, very dense masses, also which we encounter very often in the breast, where often the gun just backfires or it just semi-fires, particularly if it is of very long duration. That's one problem that we face. In which case we can choose to do a vacuum guided biopsy. This is what an equipment for vacuum looks like. So this is a console table, and this is the gun which is going into the patient for a vacuum guided biopsy. And when you put on the vacuum over here, it generates a force which helps in sucking in the tissue. So this is how biopsy is done under stereotactic guidance. So where you would position the lady and you would position your gun over here, and you make some calculations after carefully selecting the region, and then gradually enter the breast. So this is how you have to select the gun. You have to select whether it is, what kind of image you need. So this is a stereotactic biopsy. You can also have a tomo-guided biopsy. And this is how the gun really goes into the patient. The patient is awake and comfortably seated during this procedure. And this is how you would calculate the distance of the target from the tip of your needle. You make this, you come to zero gradually. So these are the steps really. So this is the gun which is going into the patient. And you then start generating the vacuum where the tissue gets sucked out. Now, this is what an MR-guided biopsy treatment looks like. All of these are special treatments, they're MR compatible, and this is what is very important to remember when you're doing an MR guided biopsy. You enter the breast with this kind of a, and whenever the going when the patient is going inside the core of the magnet, you put a plastic obturator and come out. And then you perform a vacuum guided biopsy similar to what you had seen over there. So this is an example of what the gun looks like inside the patient. This is the gun. This is what the MR would show the gun like inside the patient. These are breast clips. These are essentially placed so that we're able to delineate the tumor for for a BCS post NEC, because as you would be familiar, often the lesions completely disappear after NACT, and you need mark where the lesion was. This is what a clip looks like when you want to put it after a vacuum guided biopsy. If the lesion is still seen on ultrasound and you're doing an isolated clip procedure without a biopsy, this is what the gun looks like. And this is one of the guns developed by Dr. Tulkar and Dr. Ekta in our department. And this clip is more ecogenic. It is nicely seen on ultrasound even after NECT, which is a problem we face with clips typically. This is how the clip is placed, and this is what it looks like after clip placement, and this is what it looks like on mammogram. These are some of the wires that we use. Now, when you just have a clip or you have a non-palpable mass which is only seen on imaging, and we want to place a wire in it, then these are the kind of wires that we can put. Commonly, we use either, at least in our institution, we use this hook wire, or we use a dual lock. Not with these 4 strands, but just 2 of them. These are the common wires that we use. This is what it looks like. You go in with a needle and you deploy the wire. This is what the wire will look like. You typically cross the lesion and place it. We typically try to place the lesion over here. So you would find the tip of the wire ahead of the lesion, where we try and contain the lesion within these 3 markings of the wire. So it is supposed to be centered in the central marking, and these markings are about 1 centimeter apart. So the tip of the wire is actually about 1.5 centimeters or so ahead of the center of the lesion. This is how we try to place it. And with that, I'll end this presentation as I promised, leaving some time for some questions. I'm just stopping to share my screen. So that I'll let me just read out some of the questions. I see there are a lot of questions. Okay, it's just the transcription of my talk, I see. How much weightage to give to non-mass enhancement is one question, or background parenchymal enhancement. The background parenchymal enhancement is normal depending on the phase in which you're doing the MRI. So if you're going to do it later in the cycle or premenstrually, you will see a lot of background parenchymal enhancement. This is not suspicious. As for non-mass enhancement, I think nobody has an answer to that. We use certain descriptors such as the distribution, just like calcification. If you see it in a segmental distribution, you think it is more suspicious. If it is more scattered, you don't think it is very suspicious. If it is symmetrical, you think it's not suspicious. If it is very asymmetrical, you think it is suspicious. But by and large, I don't think there's a very good answer to that. So you either biopsy it or you just follow it up. What material is used in the clip developed by you, and how do we order it? Thank you for that question. I'll have to direct you to the other faculty in my department, Dr. Tulkar and Dr. Ekta Dhamija. Dr. Sanjay Tulkar is somebody you can email, and I could put his email ID over here so that you can contact him. it is not yet in, so we are trying to commercialize it, but since it's not, we intended it to be a low-cost device, and we're finding difficulty in finding, patrons to market it as a low-cost device. So it's still in that process. As we are on it, let me just put in Dr. Tulkar's email ID so that you can contact him for any queries on the film. So that is his email. You can always sort of contact him. So thank you, for the comments on the presentation. Quadrant division. Okay, I'll just show the quadrant division. So I think that's the last question we have. So then I'll switch back to the presentation and show the quadrants on the mammogram. So this is the lateral side by convention. So by convention, this that you see is the right side and this you see is the left side. And if you were to draw a line through the nipple, above on your screen is the lateral side and below is the medial side on a craniocaudal view. Now if you draw a line from the nipple to the pectoralis on the mediolateral oblique view, whatever is above this is the upper quadrant and whatever is below this is the lower quadrant. So if you put it together, so you can see the upper lateral quadrant or the lower medial quadrant. Basically, that's how you put it together. I hope that answers your question. I see there was another question. Difference between image of calcification of BI-RADS 3 and 4. I don't already have it. I think you should be able to see that in your practice. It's unusual to give a BI-RADS 3 for a calcification. Typically, we would either think it is suspicious enough to be biopsied or give a 4 and just follow it up. But either we think it is 2, and I showed you a lot of examples of 2. But we don't usually give a BI-RADS 3 and a BI-RADS 4 variably to calcifications. So it's usually just BI-RADS 4, and there were some of the BI-RADS 4 lesions that I had shown over there. So I think that's all the questions that there were. So Professor Som and Dr. Navneet, should we?
There's one more question: difference between the image of classification of.
Yeah, I answered that.
Kritika, thank you very much. That was a lovely talk. I thoroughly enjoyed it. Thank you very, very, very much, and wholehearted thanks on behalf of ABSI and also NB. Thank you very much. Have a nice day, and really, I thoroughly enjoyed it. Very usefully answered all the questions. Have a nice day.
Thank you. You too. Thank you for having me here. Thank you.
Thank you very much, trainees and faculty members, for joining us.